I'd like to thank the CVI 2020 Organizing Committee for the privilege of the podium. I was asked to give a presentation with the title, Best for the OR or the Cath Lab. TAVR has undoubtedly revolutionized the aortic valve replacement for aortic stenosis and become commonplace now, but we continue to refine our technique and technology involved in TAVR. And the hot topics in this arena, I would say, are mitigation of stroke risk, paravalvular leaks, permanent pacemakers, questions surrounding coronary access, valve durability, and the issues of TAVR valve explantation when that is needed. With this optic in mind, I would say there are three key questions we need to answer when choosing the treatment option for aortic stenosis, and those are patient choice, which preferably would be founded on education, including a good understanding of quantity versus quality of life, acknowledging the unknowns that we still have about TAVR, and should be put into context in awareness of temporal discounting and optimism bias that we're all subjected to. Secondly, to decide if we go to the OR or the cath lab, we need to see what arterial pathology we're dealing with. And while there are options for patients with coronary artery disease and atrial fibrillation, the devices we have currently available to address multi-valve or proximal aortic pathology are still quite limited. Finally, we need to address the risk factors for unfavorable outcome with either TAVR and SAVR, and that includes a thorough assessment of comorbidities, frailty, age and life expectancy, an understanding of what valve durability looks like, and importantly, anatomy and how it relates to some unfavorable outcomes such as poor hemodynamics, paravalvular leaks, pacemaker rates, coronary access, valve geometry. Finally, we also need to ensure that the pathology at hand is suitable for the valve chosen. And because anatomy is so important, I will use two cases to illustrate how we may decide to go either the TAVR or the SAVR route, and in those two specific cases, how that worked out for us. Case 1 is a patient with severe symptomatic aortic stenosis and Sieverts 1 bicuspid aortic valve, which in itself is a good argument for SAVR, especially in combination with a severe or complicating calcification patterns or those patients with large annulus sizes. It is common in patients with bicuspid valves. And certainly, this patient would have been a good surgical candidate also, but ultimately we decided to offer this patient a TAVR, given the strong patient preference for this modality and our assessment that this was doable with a good result. Here we have some images from the cardiac CT demonstrating the typical heavy calcification pattern of the raphe that is easily addressed during SAVR, but requires some more thought and nuance if TAVR is chosen as the treatment option. In this case, for example, this calcification can only be crushed so much with a balloon, but anatomically it is in a favorable position as it likely will force the valve away from both the right and left coronary ostium. This is an image of the heavy calcification as seen during fluoroscopy on the left hand panel, and on the right panel shows our pre-VAV with a really good waste that eventually gives. This illustrates nicely why pre-ballooning is so important in these bicuspid valves and helps prepare the landing zones for TAVR. Here's a 34mm Evolut Pro valve coming in and being deployed to 80%. We assess the position of the valve, and especially with these bicuspid valves, we shoot for a high implant of 2 to 3 millimeters. And as we release the valve completely and come over to our area we call cusp overlap view, we appreciate a significant under expansion of the valve and decide to proceed with the post-ballooning of the valve with substantial further expansion of the valve frame. So ultimately, we get a pretty good result with trace PVL on the completion angiogram and eventually no PVL on the echo the day after. These are the pre and post hemodynamics confirming the same. Overall, really a case that had many anatomic reasons to go to the OR for SAVR, where we can easily resect heavy calcifications, we can deal with a large annulus, but we managed to get a good result here with TAVR, and we're pretty happy with that. The key to this was a careful anatomic evaluation and balancing the risk, benefits, patient preference, and expected outcomes against each other. The second case I want to show was what appeared to be a straightforward TAVR case with a tricuspid valve in another low-risk patient that could also have gone to surgery. As seen here on the CT, this was a tricuspid valve. The patient was low risk by STS, predicts good risk of mortality, but deemed intermediate risk based on heart team assessment given a prior CABG with patent grafts. So because of that, we thought this patient would be better off with a TAVR rather than SAVR. The animal was measured for a 26 Evolute Pro Plus with a left coronary that was a bit on the low side at 8 millimeters, but with large SOV of 31 millimeters, and an RCA with plenty of height and SOV size to not really be concerning at all when using a 26 millimeter valve. We proceeded with TAVR, here the root shot and then the valve being deployed. Everything looks pretty good. We are letting the valve go and we have a nice result. The patient goes to the PACU. We're happy what we accomplished. But then quickly in the PACU starts having trouble with ischemic changes in the inferior wall, highly suspicious of a right coronary problem. So we immediately went back to the hybrid OR and confirmed the diagnosis of an occluded RCA. Our immediate working hypothesis was that the right coronary leaflet must have occluded the RCA, and so we decided to snare the Evolute valve and pulling it into the ascending aorta as a first order of business, while maintaining access to the ventricle. Because the reason for the RCA occlusion was not completely apparent though, and based on the information we had at the time, we decided to move forward with a balloon expanding valve rather than try another self-expanding valve on the second go here, without knowing whether this for sure will yield a different result, but certainly making coronary access easier in this specific situation. We secured access to the right coronary artery with a guide and a wire and deployed an S3 in a good position before stenting the right main coronary artery. As seen here, this restored good flow in the RCA, so in spite of what appeared to be a straightforward anatomy for TAVR, we ran into some significant issues that we were lucky to resolve. In hindsight, this patient would have been better off with surgery, all things considered. It's pretty rare for us to see coronary obstruction during SAVR, and in this case illustrates how we really subtle anatomic features may put patients at risk with TAVR. On further review of the CT and measuring the right coronary leaflet height and the other dimensions several times over, we concluded that a calcium shelf close to the RCA ostium as shown in these reconstructions here was likely the culprit, more so than the leaflet obstruction in the right coronary ostium. So who is best for the OR and who is best for the cath lab? I would say that in 2020, this is about patient choice, understanding trade-offs of early and late outcomes, treatment required for both for other pathology and risk management, especially with regards to anatomic features that are closely tied to unfavorable outcomes with TAVR. Thank you very much for your attention.